We often think of high blood pressure as something tied to, well, lifestyle choices, maybe stress, diet, things we usually associate with adults.
Right.
But imagine a baby, just a few months old, with really dangerously high blood pressure for totally different reasons. It kind of makes you rethink hypertension.
Well, what's fascinating, or maybe concerning, is that high blood pressure in children, it very often signals some kind of underlying medical issue.
Hmm.
And one of the really critical areas to look into involves the arteries feeding their kidneys.
Exactly. And well, that's the focus of our deep dive today. We're digging into a really significant piece of research here.
Yeah.
It's called Pediatric Renovascular Hypertension, 132 primary and 30 secondary operations in 97 children. Quite a title. It was published back in 2006 in the Journal of Vascular Surgery.
Ah, yes. That's a really foundational paper for understanding this. Renovascular hypertension in kids, I mean.
Right.
So this is where you have narrowed arteries going to one or both kidneys. And that causes the body to, well, ramp up blood pressure. It's important to get that the cause in kids is usually quite different from, the primary hypertension we often see in adults.
So our mission today is really to unpack this big study from the University of Michigan. They looked back at their experience over decades, actually, from 1963 all the way to 2006.
Wow, that's a long period.
It is. And what makes it so valuable is just the sheer number of surgical cases, 97 children treated for this specific, quite rare condition. It gives us this unique perspective.
Absolutely. I mean, data on that scale for a relatively uncommon pediatric condition,
Yeah.
it's invaluable for figuring out the best treatment strategies. So
Well,
where should we start? Maybe the severity these kids were facing.
yeah, good point. It's pretty striking that all but one, just one, of the 97 children in this study had hypertension that just wasn't responding to medication.
Right.
We're talking really stubborn, severe high blood pressure here.
That's a crucial point. These weren't, easily managed cases. These kids had hypertension that was resistant to the standard drugs.
And the age range is, well, it's kind of remarkable, from just 3 months old up to 17 years. It really shows this can hit kids at almost any age.
It certainly does. It underscores the broad impact. And the study, it also gives us insights into the types of artery problems they saw.
Okay.
The majority, around 80%, were developmental renal artery stenosis. So these narrowings probably happened as the child was growing.
But that wasn't the only cause, was it? There were other things going on?
No, not the whole picture. They also saw inflammatory causes and some other less common reasons for the arteries narrowing.
Hmm.
And, it gets more complex. Many of these children had other related vascular issues too. The study mentions nearly a quarter had blockages or occlusive lesions in other arteries supplying the abdominal organs.
And on top of that, a third also had abdominal aortic coarctations. That's a narrowing of the main artery, the aorta.
Exactly. Another significant vascular issue often seen alongside these kidney artery problems.
So it paints a picture of, well, interconnected vessel problems in a lot of these young patients.
Precisely. It really emphasizes that this isn't always just an isolated kidney artery thing in kids.
Mm.
It can be part of a more widespread vascular condition.
Okay, so given these, complex situations, what kind of surgeries were they actually doing?
Well, the study details quite a lot of procedures, 132 primary renal artery operations in total,
Wow.
which just gives you a sense of the intensive surgical effort involved.
And I guess the types of surgeries varied quite a bit too.
Oh, absolutely. The variety of techniques they used is really informative. It kind of reflects the different ways these narrowings can show up and, the tailored approaches the surgeons needed.
Okay, let's break some of those down. What was most common?
The most frequent, done in 49 cases, involved cutting out the narrowed bit of the renal artery
Okay.
and then stitching the healthy end directly into the aorta, the main artery.
Ah, like a direct replumb.
Pretty much. They also did similar reimplantations into the renal artery itself, or sometimes the superior mesenteric artery, though in fewer cases.
So lots of options just for that direct connection approach.
Right. And this range of techniques really underlines that, pediatric renovascular hypertension isn't a one-size-fits-all problem. Surgeons need a diverse toolkit.
Yeah.
The fact they had such high success rates despite all this variability really speaks to the specialized expertise needed.
Makes sense. So that direct implantation, the goal is just to bypass the bad section entirely.
Exactly. Connect the healthy part of the kidney artery to a big healthy vessel like the aorta. Where they connect it depends on, the location and extent of the narrowing and what gives the best blood flow without putting too much tension on the repair.
Okay. What else did they do besides direct reconnection?
Well, another common strategy was creating a detour,
Mm-hmm.
essentially. The study mentions 40 cases of aortorenal or ileorenal bypasses.
Bypass, okay. How does that work?
It involves using a graft, maybe a piece of vein, or sometimes a section of the patient's own iliac artery to create a whole new path for blood to get to the kidney, going around the blockage.
Got it. So that's an alternative if direct reimplantation isn't the best fit.
Precisely.
Hmm.
If it's not feasible or maybe not the ideal option for that specific case.
Interesting. Then in 10 cases, they did something called focal arterioplasty. What's that?
That's more like surgically repairing the narrowed section itself, almost like patching it up.
Okay.
And in a few instances, maybe 4, they could actually cut out the narrowed bit and just reconnect the healthy ends of the artery directly end to end.
So different ways to fix the artery in place.
Right. Arterioplasty is usually for shorter, more localized narrowings. Resection and reanastomosis works best if the bad segment is short enough that you can join the ends without, pulling them too tight.
And they even tried operative dilation, like stretching it open during surgery.
Yeah, in 4 cases. A bit like angioplasty, but done during the open operation. And in a couple of very specific situations, they did a splenorenal bypass.
Splenorenal, connecting the spleen artery to the kidney artery.
Exactly. That's a more specialized technique used when the main renal artery is really badly diseased or hard to get to.
But sometimes, I guess, reconstruction just wasn't an option.
Unfortunately, yes. In 13 cases, they couldn't restore good blood flow, and the only option was a primary nephrectomy, removing the affected kidney.
That's tough.
It becomes necessary when you just can't fix the blood supply, and that poorly functioning kidney is actually driving the high blood pressure.
It's also pretty sobering that 34 kids needed surgery on both kidneys.
Yeah, bilateral involvement.
Mm.
That significantly ramps up the complexity of the surgery. Needs really meticulous planning and execution.
And it wasn't always just the kidney arteries. You mentioned other vessels.
Right. The surgeons often had to deal with issues in other abdominal arteries, too. 17 kids had procedures on their celiac or superior mesenteric arteries. Those supply the gut.
Okay.
And remarkably, in 15 of those cases, they did it at the same time as the kidney surgery. It shows a really integrated approach.
Fixing everything at once.
Yeah, that simultaneous approach is often vital. Addressing all the major narrowings in one go can lead to better overall outcomes and hopefully reduce the need for more surgeries down the line.
And then there were the aortic reconstructions you mentioned earlier, 30 of those.
30 abdominal aortic reconstructions, yes.
Yeah.
Mostly using either patch aortoplasty, widening the aorta with a patch in 19 cases,
Right.
or a more expensive thoracoabdominal bypass in 11. Again, most of those, 25, were done concurrently with the renal artery operations.
It just highlights how connected these vascular problems can be.
It really does.
But despite all this effort, sometimes more surgery was needed.
That's the tough part. The study notes that 30 secondary renal artery procedures were needed later on in 19 of the patients.
And that included more kidney removals.
Yes. Sadly, 9 additional nephrectomies were part of those secondary procedures. It just shows that managing pediatric renovascular hypertension can be a long-term challenge, and the first surgery isn't always the final answer.
Okay, so with all these incredibly complex surgeries, what were the actual results? This is, the crucial part.
Well, the outcomes reported here are actually very encouraging, really positive overall.
Yeah.
They found that hypertension was completely cured in 68 of the children. That's a solid 70%.
70% cured. Wow.
And in another 26 kids, so 27%, their hypertension showed marked improvement, significant improvement.
So wait, add that up. 70 plus 27. That's 97% who saw a benefit, cured or improved.
Exactly. 94 out of the 97 children had a positive outcome.
That's huge. What about the other 3?
In only those 3 kids did the hypertension remain unchanged.
So a 97% benefit rate overall, that really speaks volumes about what surgery could achieve here.
It really does. It shows the potential of surgical intervention, when applied to carefully selected patients by an experienced team.
What about the long term? Did they follow these kids for a while?
Yeah, the average follow-up was 4.2 years. But there was a really wide range, some only for 3 months, but others up to an incredible 42 years.
42 years.
I know. Though the authors do rightly point out that the shorter follow-up in some patients is a limitation if you're trying to understand the long-term durability of the cure.
Sure, that makes sense. But here's something really critical from the study. No patients ended up needing dialysis.
Right.
And maybe even more importantly, there were no deaths directly related to the surgery itself.
Zero operative mortality. That's a powerful statement.
Absolutely. Especially given how complex these surgeries sound, it says a lot about the safety and the level of expertise at that center.
Definitely. Avoiding dialysis and having no operative deaths in such intricate pediatric vascular cases, it really underscores the progress made in treating this condition surgically.
Now, the paper also included an expert commentary, giving some outside perspective. What were the main points from that?
Well, the commentary really reinforces the study's value, calling it a key insight into surgical treatment at a single highly experienced place during that time.
Okay.
They reiterate that the focus was on kids with persistent hypertension from blocked renal arteries who had surgery, and they specifically mention, that patients over 18 were excluded.
And did the commentary agree with the main findings?
Pretty much, yeah. It highlights that same emphasis on uh, directly implanting the healthy renal artery into the aorta beyond the blockage, and also the importance of tackling those other aortic or abdominal artery issues at the same time.
Right, the combined procedure.
Exactly. And they also underscore that impressive 97% benefit rate.
But commentaries often point out limitations too, right?
They did. It notes that, being a retrospective study from just one center, there are inherent limits on how widely you can generalize the findings. And also that variable follow-up time we mentioned means we don't have a complete long-term picture for every single patient.
Okay, so putting this study in a bigger context is important. How common is high blood pressure in kids generally, and where does this renovascular type fit in?
Good question. The commentary mentions the overall prevalence of clinical hypertension in kids and teens is around 3.5%. Less common than adults, sure, but still significant.
Right.
And when you look at secondary causes, meaning high blood pressure caused by something else, renal, meaning kidney disease and renovascular disease, like in this study, are quite common causes.
Yeah.
Second only to primary hypertension, which is high blood pressure without a clear underlying cause identified.
But it sounds like actually finding the kids who might have this specific renal artery stenosis can be tricky. No clear guidelines.
That's right. The American Academy of Pediatrics even acknowledges there isn't robust evidence for screening criteria.
Yeah.
But, experts tend to look closer at kids with very high blood pressure, like stage 2, or those showing heart issues related to the pressure, or kids with high blood pressure and low potassium levels, or maybe if imaging shows one kidney is noticeably smaller than the other. Those are kind of red flags.
So how did the results from this Michigan study stack up against what other big centers were seeing around that time?
That's important for perspective. The 70% cure and 27% improvement rates here, they're generally in line with some other major historical series, like from the Cleveland Clinic, and a combined report from Vanderbilt and Children's Hospital Philadelphia.
Okay, so comparable to some others.
Yes, but interestingly, a more recent study, though still a while back, from Great Ormond Street in London, reported a lower cure rate, only 46%.
Huh. Why the difference, potentially?
Well, it suggests outcomes can vary between institutions. It likely reflects differences in, the specific patient groups they see, maybe subtle differences in surgical techniques, or even the timing of when they intervene.
That variability really highlights how significant the experience at Michigan might have been.
What about less invasive approaches, things like angioplasty, using balloons to open the artery? Are those used more now?
They are, yes. Endovascular interventions are increasingly used for pediatric renovascular disease.
And how do they compare?
Well, while they're technically possible, the evidence, at least around the time of this commentary, suggested the blood pressure benefits might not be quite as good as with open surgery.
Really?
Yeah, different studies reported benefit rates maybe around 54% to 69%. And a known issue is restenosis, the artery narrowing down again after angioplasty. That seems to be more of a problem in kids, especially those with conditions like neurofibromatosis type 1 or NF1.
So open surgery might still have an edge for blood pressure outcomes despite being more invasive.
It appeared that way based on the data available then. And the commentary also noted that even repeat open surgeries could have limited benefits in some of the most complex cases.
That sounds like a real challenge for those kids.
You.
It definitely is. The more complex the underlying issue, the harder it is to get a lasting fix.
It's interesting that commentary also mentions newer unpublished data from Michigan at that time, looking at even more kids, 169 of them. What did that suggest?
That more recent data hinted at slightly different cure and improvement rates. And importantly, it started to identify factors like the child's age at surgery or having that aortic coarctation we talked about as potential predictors for needing more surgery later on. It also suggested kids needing repeat operations were less likely to get their hypertension completely resolved.
So a continuous learning process.
Absolutely. It shows the ongoing effort to really refine understanding and treatment, especially for specific subgroups.
This study also went into quite a bit of detail about the specific surgical techniques and practices they favored. What were some of those key principles?
Yeah, the authors highlighted several things. They routinely used a specific kind of incision, supraumbilical transverse, and a technique called medial visceral reflection to get good access to the aorta and renal arteries. They also emphasized using certain medications during surgery, anticoagulants like heparin, antiplatelet therapy, and things to support kidney function, like mannitol for osmotic diuresis.
It sounds like they were really focused on preserving any existing blood flow, too.
Very much so. They prioritized in situ reconstructions whenever possible. That means repairing the existing arteries where they lie, trying not to disconnect them completely to preserve any collateral blood vessels that might be helping out.
And doing everything in one go.
Yes, favoring single-stage operations for those combined aortic and mesenteric artery problems we discussed.
Did they mention specific techniques for, say, connecting the renal artery back to the aorta?
They did. They described spatulating the renal artery, kind of widening the opening and using interrupted sutures, individual stitches, to attach it. And they mentioned using the internal iliac artery from the pelvis area as a good graft source when they needed to do a bypass.
And for fixing the aorta itself?
They noted using ePTFE grafts, that's a synthetic material, and being mindful of the patient's size. For the aortic coarctation, the narrowing, they generally preferred patch aortoplasty over the bigger thoracoabdominal bypass if the anatomy allowed it.
And using a big enough patch.
Critically important.
Yeah.
They stressed using patches large enough to allow for the child's future growth.
Yeah.
You don't want the patch to become restrictive later on.
And just to circle back, the most common kidney-specific surgery was that direct reimplantation onto the aorta.
That's correct. That was the main technique they used for the renal artery stenosis itself.
Okay, so to kind of bring this all together, what's the big picture impact, the main conclusion from this really substantial study?
Well, this study really stands out as a landmark paper. It represented the largest single-center experience in surgically managing this condition in children at the time it was published.
Right.
And the authors demonstrated truly excellent surgical outcomes. That very high rate of hypertension benefit, 97%, combined with no patients needing dialysis and zero operative mortality.
Yeah, those are key stats.
Absolutely. So their findings strongly support the role of open surgical reconstruction for, carefully selected children with renovascular hypertension.
Right.
But, crucially, performed at specialized medical centers with experienced multidisciplinary teams.
Yeah.
It's not something done everywhere.
So the key takeaway for you listening is that for children facing this specific type of hypertension, renovascular, that isn't controlled by medication, surgery can be a remarkably effective option, leading to a cure or significant improvement for the vast majority, as this huge Michigan study really showed us.
And it's also vital to remember just how complex this condition is, and the importance of seeking care at those specialized centers that have the expertise and all the resources needed to handle these really challenging cases.
Yeah, and it really makes you think, doesn't it? How does understanding these rarer conditions in kids like this one feed into our broader medical knowledge?
That's a great point.
Could the insights from these specific surgeries, these specific kids, offer lessons for, say, vascular diseases in adults, or maybe even spark ideas for treating more common types of hypertension? And how incredibly valuable is that long-term follow-up, like seeing kids tracked for decades, for truly understanding pediatric health and the real lasting impact of what we do?
It's a continuous journey, isn't it? Constantly learning, constantly refining, even for diseases that might seem uncommon. There's always more to understand.